Endoscopic mucosal resection is traditionally used in Japan to treat mucosal colorectal carcinoma. However, EMR is associated with a relatively high risk of local recurrence when performed piecemeal. Recently, the endoscopic submucosal dissection (ESD) technique was developed to resect large neoplasms en bloc and to reduce the risk of recurrence. ESD was initially designed for treating large early gastric cancers, but more recently it has also been used for removing laterally spreading tumors, LSTs, in the colorectum, in particular those determined by high magnification chromoendoscopy to be either mucosal or submucosal superficial invasive carcinoma, that is less than 1000 micromillimeters from the muscularis mucosa. Because of the risk of lymph node metastasis, laparoscopic-assisted colorectal surgery is the treatment method of choice for removing lesions with deeper submucosal invasion. At present, no data are available about the comparative effectiveness of endoscopic versus laparoscopic resection of early colorectal cancer. Given the significant differences between the two techniques in terms of their potential benefits and risks, such data, however, would be important. In this study, Kiriyama et al. Aimed to compare clinical outcomes in patients who underwent ESD and those who underwent LAC. Because endoscopic and laparoscopic resections have been standard practice in their institutions, they could not perform a randomized trial. In the November issue of Endoscopy, they report the results of their cohort study in the article entitled Comparison of Endoscopic Submucosal Dissection with Laparoscopic-Assisted Colorectal Surgery for Early-Stage Colorectal Cancer, a Retrospective Analysis. Endoscopic submucosal dissection is increasingly being used to resect early colorectal carcinoma, despite the technical difficulties associated with this procedure. Laparoscopic-assisted colorectal surgery is an alternative to open surgery for colorectal cancers, and ESD was recently introduced as another alternative. In this study, we compared ESD with LAC as minimally invasive treatments for early colorectal cancer. The study included 589 patients, 297 patients with colorectal intramucosal or slightly submucosal invasive cancers undergoing ESD, 292 patients with T1 colorectal cancers undergoing LAC, who were treated at National Cancer Center Hospital in Tokyo, Japan, between January 1998 and September 2008. The clinical outcomes of ESD and LAC were evaluated retrospectively and compared on the basis of data that were originally collected prospectively. In the ESD group, mean tumor size was 37 millimeters, mean procedure time was 106 minutes, and the en bloc and curative resection rates were 87% and 80% respectively. There were 14 perforations, 4.7%, and 5 cases of post-procedure bleeding, 1.7%. All complications were successfully managed endoscopically except for one of the perforations which required emergency surgery. In the LAC group, mean tumor size was 20 millimeters, mean operation time was 206 minutes, and complications included 31 wound infections, 2 pelvic abscesses, 3 anastomotic leakages, and 1 anastomotic bleed. Stomas were necessary in 93% of the patients who underwent LAC for rectal cancers located below the peritoneal reflection. The authors conclude, ESD was associated with a lower complication rate than LAC, with favorable en bloc and curative resection rates. The safety profile and possibility of curative treatment with colorectal ESD provide advantages for the treatment of early colorectal cancers with null risk of lymph node metastasis.